All right, we will call the Health Committee for March 20th. And Michael Ann, would you call roll?
Representative Lee?
Here.
Representative Lipscomb?
Here.
Representative Hall?
Here.
Representative Sorrells? Here. Representative Mooney? Representative Warren? Representative Marcus?
Here.
Representative Gray? Here. Representative Rafferty?
Here.
Representative Paramore? Here. Representative Rigsby? Representative Holt Jones? Here. Representative DeBose? Representative Shiree? Representative Brinyard? You have a quorum.
Thank you. We have two bills on the agenda today. We will vote on the first one. And if you're here for that, if you would like to stay for the public hearing, you're welcome to. But if not, if you can move out, I think we have people in the hallway that would like to hear the public hearing. First bill on the calendar today will be HB 158 for Representative Colvin.
Thank you, Mr. Chairman and committee. Mr. Chairman, thank you for your patience with me on this bill. I had to carry it over 2 weeks ago, so appreciate you allowing us to continue to work on this bill. Members, this bill would prohibit governmental entities and the state health officer from imposing any face mask mandates to prevent the spread of COVID-19 or any variant of COVID-19. This bill does provide exceptions for facilities offering medical or dental services and state and local detention facilities. The definition of governmental entity includes, but is not limited to, a state, county, or municipality, any instrument of the state, county, or municipality, public K through 12 or public charter school, and of course the state health officer becomes effective October 1st, 2024. That is pretty much it. We do have a friendly amendment that I believe is going to be offered by Representative Shiree, and what that is for the universities. I thought they would already be covered in the medical or dental facilities. They came to me asking about nursing clinicals at their campus and those medical and research labs. So we're going to offer an amendment to allow that exemption as well. And so that is it. I'll be happy to entertain any questions.
Any Representative Hall?
So could you tell me why you feel this is necessary?
Yes, ma'am. Through even after the pandemic, including now, after like every year, there's a scare. People wondering, is COVID going to come back, including some of the lockdowns we saw on the local, state, and federal level. Really what sparked my interest in this issue was I had students come up to me and ask me what the state could do in order to prevent them having to go to school just in a classroom setting and worrying about having to wear a mask, and they just want to go to school to learn. So I'm really here today to stand up for those students who just want to go to school and learn. And I thought this bill would accomplish my goal. And I do want to be clear, this bill does not prohibit in any way the private sector. This is just going after governmental entities. I'll make that very clear.
So I noticed you have, so the other schools, so you're specifically concerned about students that are in school other than public schools?
This would go after public. This would not, private schools would not be under this bill.
Yeah, that's what I'm asking.
Taxpayer-funded entities.
Thank you.
State and local.
Yes. Yes.
Not a lot we can do about the federal.
Unfortunately not.
Okay.
I'm trying to.
All right. Any other questions? We have an amendment, and you have it in your packet. And so he has addressed the amendment, so I need a motion on the amendment for the bill. Representative Lipscomb makes a motion. Second, Representative Paramore. All those in favor to add the amendment by saying aye. Aye. Those against, nay. Amendment passes. Now I need a motion for the bill as amended. Motion, Representative Shiree. Representative DeBose, second. All those in favor by saying aye. Aye. Those against, nay. No, one nay. All right.
Thank you, Mr. Chairman.
Thank you. Looks like everyone's here for this next bill. We don't have boring meetings here. We have a room full every week. So next bill, Representative Holtze, HB 232.
Thank you, Chairman, members. Good morning. It's nice to see everyone. I'm going to be honest. I haven't done this before, and I know we are not voting on anything today necessarily and just having a public hearing. What specifically would you like for me to do since we're still trying to figure out bill language?
What the bill that you introduce is what you need to discuss.
All right, I'm going to grab that real quick.
Okay. There has been work done on this. Representative Lipscomb and a group of committees have worked on trying to get some kind of agreement, and they're close. We will, after today, with numerous questions I'm assuming that we will have, it may give us opportunity to get us across the finish line, that we can come to some sort of agreement with both sides and hopefully have some sort of agreement by next week of where we're going to land on this. Anytime there is any type of expansion, it is very important that we are very careful and do our homework on every part to make sure that both entities are getting a fair share of it, fair share in how it's treated. So I don't want anybody to think we've rushed anything through. Go ahead.
Thank you, Chairman. So HB 232 it's obviously PT bill. So essentially what this bill does is it defines the Physical Therapy Practice Act and the scope of practice of physical therapists licensed in Alabama. This bill will allow licensed physical therapists to conduct initial screenings of patients, and it would eliminate the requirement that physical therapy be practiced only upon a referral from a licensed physician, dentist, chiropractor, physician's assistant, or a licensed certified registered nurse practitioner.
Okay. We have several here. I'm going to let Michael Ann call. We have 4 supportive, 4 opposed, and we're going to hold it to 3 minutes per. And if you're in the middle of a conversation for it or against it, one or the other, we're going to cut you off in 3 minutes. So, okay.
Doug Cole.
Morning. Thank you for allowing me some time to speak on behalf of this bill. Just a quick note, and I'm sure y'all are aware of this, demographics rule the day when it comes to healthcare and access to healthcare. As we currently sit, there's 72 million baby boomers, and what a lot of people don't realize, there's 75 million millennials coming behind them, an even bigger group. We're going to have an access problem. We're going to have a problem meeting all the needs and the demands of those patients. That's one of the main reasons we're coming at it, from the angle we're coming at it, is to try to improve access for patients, not just today, but coming down the road. I've been practicing for 23 years in the state of Alabama. I currently work in a setting where I do a lot of hiring of physical therapists. Literally 2 weeks ago, had a therapist tell me he was not going to come back to Alabama because he did not have the ability to practice at the top of his license. Most every other state in the nation has that ability to access their patients unrestricted. And so that's, that hurts, because we as Alabamians know that demand is going to continue to be there. And if we can't encourage our own people to come back to our state to service that, we're going to have a problem. And that's not just today, that's going to be down the road, because those demographics don't lie. So I would urge y'all to look at this. It's not really an expansion of scope. We're not asking to do anything new. We're not asking to perform surgery or to do injections or anything like that. We're just saying, hey, let's grease the wheels and make it easier to access the services that frankly, our citizens are demanding. And when they can't access that quickly, they're going elsewhere. They're going to unlicensed professionals to look for those services. We fit very, very nicely into a spot where we can provide services underneath our license. So it's not asking for an expansion of scope. It's asking, hey, let's help our citizens access what they need quicker. I'm happy to answer any questions if anybody has any.
And we may have some at the end.
Okay. Thank you.
Hopefully we do.
Okay. Thank you for your time.
Dr. Brad Russell.
Members, thank you for this opportunity to address you regarding this bill. My name is Brad Russell. I hold positions with the American Chiropractic Association, the Alabama State Chiropractic Association, as well as the Alabama State Board of Chiropractic Examiners. And in that capacity, I'm very concerned with public safety, and that's really what this bill boils down to. The concern for, it's been clearly established that physical therapists have not been trained as physicians, that they cannot differentially diagnose. They haven't been trained in lab diagnosis or imaging. I think they're uniquely unprepared to fill a portal of entry position into the healthcare system. This bill provides unfettered patient access. We don't allow dental hygienists to act as dentists, nor do we allow paralegals to act as lawyers. Even physician extenders, who have much more training than PTs in evaluation and management services, such as nurse practitioners and physician assistants, practice underneath a physician. There does appear to be a certain sensitivity to scope expansion amongst the legislature, and we share that sensitivity. We're in favor of a profession being able to do anything they are trained to do. However, in this situation, the PTs are not trained and therefore are asking to assume unearned responsibilities. We would suggest they go back, rework their educational standards, and create an education system commensurate with other professions providing physician-level services, and then come back. It's unlikely you would see any objections in that situation in this scenario. In prior testimony in front of this committee, I described several potential catastrophic situations that could occur without appropriate evaluation and diagnosis. And the rebuttal for that was those are rare events and obscure events, and I'll argue that that doesn't obviate the concern if it's you or your family member in that situation. Very quickly, I want to outline one more situation for you that happens all the time in our practice. And this is something that I don't see how a physical therapist, with their tools that they have, could find. Adolescent athletes present to our clinic with back pain all of the time. That patient often needs an MRI, and they almost every time need an X-ray. There are things there that you cannot determine based on a question and answer and a physical exam. In this particular situation, I'll describe one that happened last week. Patient came in, no red flags, no yellow flags, typical back pain. It looked like mechanical back pain, and at that point, after an exam, the PT would be required to make a decision to treat or not treat. We went ahead, took the X-ray. The X-ray was negative. Fine. We went on to do the MRI. The patient had a fracture in process. When you looked at the MRI image, there was inflammation, there was marrow edema in a specific part of the vertebra called the pars interarticularis. Unaddressed, that patient would go on to have a full-bore fracture and would be a lifelong injury for that patient.
Tom.
Thank you.
Thank you very much.
Thank you.
Johnny Burnett.
Chairman Lee, members of the committee, thank you. I'm Johnny Burnett. I'm a vice president of the Alabama chapter of the American Physical Therapy Association, and I'm a doctor of physical therapy. I'm a board certified specialist in orthopedics. I'm a member of the fellowship of the American Academy of Orthopedic Manual Physical Therapists, and I've gone through a lot of training. I've spent a lot of money. I've learned a lot about how to deliver my discipline or my specialty, which is physical therapy. So I could speak right now about, access to care is the big issue. The patients I deal with for 20-something years have asked me, why can't I come see you? Physicians tell me this. If you go to your communities, talk to your doctors and nurses and see, they'll say, physical therapists should be able to see patients. It's the access issue. It's given people the choice. You're offering them a choice to see us and let us deliver our services that we're designed to do. So I have patients that walk in that have had imaging. I can tell you about a 13-year-old boy that I saw walking in our clinic, and I said immediately, the way he was walking, he had a serious problem with his hip. He was referred from a primary care physician who had x-rays that were negative, but I examined him, and I realized that hip meets the classifications of a possible slip capital epiphysis, and I sent him to the orthopedic surgeon. The orthopedic surgeon called me back and said, that's a great catch. This kid needs surgery. He needed it now. He said, I can't believe they didn't catch it. So the imaging will only get you so far. The pain issue with the low back, well, if you just say pain, It's the way you examine the patient. I would recognize that that pain pattern does not make sense. It doesn't respond. I can't turn those symptoms on and off. That's a red flag. That's a red flag to me. I would say this doesn't behave the way it should. So therefore, you need to go get imaging. You need to go to the next level. So that's what we would do. We would be able to recognize when things don't fit where they belong, and we would improve the healthcare costs that are the access to care problem is real. It's getting worse. We have 10 clinics. I'm an owner of 10 clinics across South Alabama. A lot of them in rural areas, and the access to care is a serious problem. So why would you not just give people a choice to choose to come see us? If we deliver value to them, they'll decide how often they see us, when they see us, and our plan of care for them is really to manage them throughout their lifespan, to prevent problems. So patients are interested in, well, why is my shoulder hurting? And we show them the mechanical reason why it's starting to tear up. We're the only providers in the healthcare system that are doing this. But we can't get access to the 92% of people that we could help because what we do as physical therapists, we look at physical therapy problems. We don't need the medical diagnosis to do what we do.
Time.
Okay, thank you.
Thank you.
Could go on
Thank,
forever.
very good. Thank you.
Dr. Ken Randolph.
Thank you, Mr. Chairman. Thank you, committee. My name is Dr. Ken Randolph. I've been a chiropractor for 27 years. I'm a fourth generation chiropractor. I've also sat on the Alabama State Board of Examiners for 16 years, one of the longest serving members. We know that our job is to protect the public. The reason I'm here today is because of my concern for that. I just want to make this really simple, and I want to ask you guys a question you don't have to answer except to yourselves. But every time you've ever stepped into a primary care office to see someone, you've had an exam, you've had them diagnose, and you've had x-rays. There's a reason for that. We all know there's a reason for that. My concern with this is not that I'm against the PTs, not at all. What I'm against is what they're asking for, to simply be turned over, to be allowed to do what they have not been doing, and they're not really qualified to do. They would argue with me about that, but here's the deal. We take 4,200 hours to become a chiropractor. They're nowhere near that. They don't take a lot of the courses that are necessary to be able to do these things. I'm fine if they want to do those things. If they want to add that to their curriculum, they want to be part of that, I'm all about it. They want to come back and do that. I don't think you're going to hear us be opposed, but as this stands right now, this is a danger to the public. It's that simple. Thank you.
Heather Mount.
Good morning. Thank you so much for allowing me to speak today. My name is Heather Mount. I am the founding program director at Faulkner University's Department of Physical Therapy. It sounds like there's a lot of questions about what our education is, and so I'm here to kind of dispel any misinformation there might be. And you might see some of our students here today, and they can share with you the courses that we teach if you have questions specific to what we do here. But all of the programs in the United States of America are under one accrediting body called CAPTE. CAPTE has standards that we must meet. Every single program in the state, in every single state, has to meet these requirements. Because direct access, or this access we're asking for, has been a part of physical therapy in other states for almost 50 years, right? It's been at least 50 years in some states out west. We're required to teach our students how to practice in a direct access environment. It doesn't matter what the jurisdictional requirements are in each state, because CAPTE is all over all 50 states, we have to meet those same requirements. So in addition to that, all of the military personnel and VA PTs all go through the same accreditation process. And in the VA and the military, they've been doing direct access for some time. As a matter of fact, direct access has gone so well that now they're actually inserting PTs into primary care. By 2025, there'll be a PT in every primary care area in the VA. So CAPTE requires that all of our students learn anatomy, physiology, pathology, differential diagnosis. Specifically, they mentioned that, diagnostic imaging, pharmacology, and using evidence. We call it evidence-based practice. So we teach about students how to use evidence to be able to make clinical decisions. That pathology classes that we take, we look at all the systems. We look at the immune system, the endocrine system. We look at the gastrointestinal system, because those systems do mimic musculoskeletal pathology. A lot of those conditions will produce aches and pains in the shoulder and in the knee, have muscle pain. And so we have to teach our students how to differentiate between what is a musculoskeletal problem that we can treat and what is something else that needs to be referred. We're required to actually go through the process of talking about how do we refer patients back to the physician. What is the communication? What is the documentation? So we do a thorough history. We ask all kinds of questions, not only about the musculoskeletal system, but also all the other systems. From there, if we're concerned, we know how to test those systems to see whether there is something we need to investigate more. If we find something, our students will refer. In addition to that, we study pharmacology, because a lot of times the medications will cause side effects, or there'll be drug interactions. And it might look like a shoulder problem, but it's actually not. There are a lot of medications like fluoroquinones that can cause those types of symptoms. And so we teach our students how to recognize that. Okay? In addition, although we cannot order in this state diagnostic imaging, there are 11 states currently in the United States that allow PTs.
Thank you. You got a lot of words in.
Dr. Pete DeFranco.
Thank you, Mr. Chairman and members of the Health Committee. My name is Dr. Peter DeFranco. I practice in Hueytown, Alabama, live in Hoover, Alabama. I've been in practice this year 40 years. And during this 40 years, I've seen just about everything. I've had a lot of patients come in with low back pain that wasn't low back pain. You know, a lot of things cause low back pain that you could never think of. Everything from your prostate, gallbladder, stomach, spleen, intestines. A lot of conditions cause low back pain. One of the number one symptoms a stroke patient has that comes into your office is neck pain. Now, I've looked at the physical therapy curriculum. I've reviewed a lot of their literature, and their differential diagnosis is not sufficient. Their understanding of lab diagnosis is not sufficient. Their understanding of radiology, MRIs, CAT scans, PET scans, they're not getting any of that. They can't order it. They can't even take an x-ray. The number one thing that physical therapists misdiagnose in a Canadian study is a fracture. They miss a fracture because they can't take an x-ray. Now, I'm not trying to be disparaging against the physical therapists. I like physical therapists. I refer to them. But having direct access, it's not a matter of something that you should just, oh, we're going to let them have a direct access. This is a serious matter that you're unleashing here. It's serious. If you can't order lab studies, you can't order an MRI, this is serious. They're going to miss stuff. And I heard in the subcommittee talk about malpractice. Let me tell you, that's proprietary. No one knows what malpractice premiums anybody has because no one releases them. They're not released. But I'll tell you this much, you get direct access and you start having to be responsible for a patient's health, it is going to increase. Because right now, there's 2 files that has to be filed, be reviewed in a malpractice case. The physician who referred it and the physical therapist. The liability is really on the referring physician, not the PT. You change that, that malpractice rate will go up, particularly if you can't order an X-ray.
Time.
Thank you.
Thank you.
Emmett Parker.
Mr. Chairman, honorable members of the House Health Committee, thank you for allowing me to speak today. My name is Emmett Parker. I am a physical therapist from Birmingham, Alabama, native Alabamian, lived here my entire life. Want to address some of these things that have been brought up. First of all, the bill is an access bill. It's not an expansion of scope bill. It is unrestricted direct access in its original form. Okay. The comments that are being made about the safety are simply baseless and without merit. And we have the evidence to support that. CNA, which is the largest malpractice carrier for physical therapists in the country, okay, has released the data on this. And there is no increased risk to physical therapists practicing in an unrestricted model versus a strict referral model. None. Zero. They say no difference in claims. And this has been over decades. This is not something new. 21 states have unrestricted direct access, okay? So this notion that we're not educated and trained, this notion that we're incapable of making these difficult decisions simply is not true. We're trained, our curriculum is very stringent. Gross anatomy, neuroanatomy, neurophysiology, pathology, pathophysiology. We have to be able to recognize these things. And there are clinical exams you can do that have as much sensitivity and specificity as MRIs and X-rays and imaging does. I mean, again, these are studies that have been done. And if you stack special tests, likelihood ratio and stuff, it all, turns out to be really good. So, okay, that's not distracting. But anyway, we've done direct access in this state since 2012 with training wheels, okay? We've had unrestricted evaluations for 12 years. There's been no issues. We haven't harmed anybody. There's been no complaints, okay? We're just simply trying to take the training wheels off. And we have a distressed healthcare system in the state of Alabama, okay? We need this. We have a rural healthcare crisis. We need this. It is safe. All the data shows that. It's a great idea. It's a great bill. It will help everybody, okay? There's no downside to this. Chiropractors, doctors, orthopedists, everybody are gainfully employed in all of the states that have unrestricted direct access, okay? So anyway, in closing, I appreciate you guys and the hard work you're doing. I appreciate the opportunity to speak with you about this. And if you have any questions, I'll be happy to answer them.
Thank you.
Nico Corley.
Good morning, Mr. Chairman, members of the committee. Thank you for the opportunity to speak this morning. I want to give you some brief history of this issue since I've been with the Medical Association now 16 years, hard to believe. So in 2012, as Mr. Parker referenced, there was negotiations took place, additional negotiations took place. Leading up to 2020, there was another agreement reached in 2020, but like many things that session, COVID and what happened with our session killed basically everything but the budgets, as y'all will recall. So the importance to us in this is that we don't discount the diagnosis. We toss that term around lightly sometimes, and the importance of a diagnosis from a qualified individual, and those people are currently listed as those who can refer to a physical therapist. The importance of a diagnosis rules out all the things that a movement disorder may not be. Things that testing and labs, things that are critically important diagnostic tools to identify what something is and maybe what something is not. Because PT is a therapy. Just like a drug is a therapy, just like surgery is a treatment for a condition that then may lead to therapy. If we turn that around and put therapy as a frontline access point, we really reverse the intended order, right? PTs are incredibly qualified and do a fantastic job working with my urologists, with my orthopedic surgeons, my family medicine docs that we represent. But it is a process that needs to be followed to ensure that patients get the care they need and that patients get the appropriate access that they need to be able to take care of the condition they have, not just PT for any condition. So as we look at the concerns that we have on this, we know of no access to PT crisis. We don't see how this legislation or something like this is somehow going to improve access to care across the state. You cannot replace the frontline personnel, the doctors, nurses, nurse practitioners, PAs, chiropractors, and others that are frontline diagnosticians running through the things that something is not before they determine, hey, we do need to do PT on a patient, and we do need to send them to somebody qualified to do that. So that's a significant concern for us. Also, so you know, the VA is not a fee-for-service healthcare system. There's a huge difference between an encapsulated, tightly knit, interwoven healthcare system and a fee-for-service universe. Two totally different dynamics, and you can't make those two things identical. So our concerns additionally go on to the fact that this bill would grandfather in any PT that is currently practicing. This committee has historically only allowed those expansion of scopes when there's a differential between the individuals in that group. Licensed clinical social workers last year, and podiatrists to only the most highly trained individuals within that respective discipline of healthcare. So again, you've got doctors of physical therapy in Alabama, you have master's trained physical therapists in Alabama. There's a huge difference there, likely there, but this would grandfather everybody to be able to be a frontline diagnostician, which we do not believe is appropriate. In closing, I just want to thank you for the committee's diligence. There's been a tremendous amount of work and conversation that have gone into this. There's obviously going to be more that takes place after this point, but I am also here to happily answer any questions and provide other information. Thank you.
Thank you. Was that it? Representative Halsey? All right, let's open it up to the floor for the members for any questions. And Representative, if you need any help in answering any questions, feel free to call. This is an opportunity for us to all just kind of lay it on the line and see where we are with our questions and answers. Yes, sir. Representative Marcus.
Thank you, Mr. Chairman. My question is, the bill that's in front of us, is this what came out of the subcommittee, or is this the original bill?
This is the original bill.
Thank you.
You're welcome.
Representative Shirey.
So I have several questions. I'm hearing a lot from the people who oppose this bill about diagnostic imaging. Should we allow PTs to order diagnostic imaging and get the results from a radiologist? Have the radiologist do the interpretation report of the diagnostic imaging? I guess I'll open that up to anybody who might want to address that.
Yeah, I'll definitely let someone else address that. But I will say, I mean, to the point of several comments that have been made, on both sides, and obviously, there are differing agreements about this. But I've had numerous MRIs in my lifetime because apparently I like to fall apart. And honestly, every single MRI I've ever had was incorrect anyway. The imaging was not correct. It did not actually show what was going on. I know that's just me in one case, but I don't know that that's something that concerns me at the level that it maybe concerns several in this room, and I can respect that difference, but I don't know that it's that big of a deal. I don't know who would like to answer that question.
No. Oh, you good? You're good.
2 seconds.
Okay.
He has a lot of questions.
Okay, all right. So I wanted to talk a little bit more about diagnostic imaging, and we teach our students about all the different types of imaging, from MRI, CT, radiology, fluoroscopy, things like that. But what's really important about diagnostic imaging for us is that we have evidence, clinical prediction rules. We use the American College of Radiology's appropriateness criteria to determine if imaging is warranted, and then if it is, what type of imaging. So sometimes we'll get patients that maybe have had a radiograph, but if we look at the Canadian C-spine rules and we look and see if they've had a fall, the first line of imaging for a cervical spine is probably not going to be radiographs. It's not going to be really good to diagnose a fracture in the upper cervical spine. You'd really want to do it with a CT or MRI. And so we would look at that and see if the patient didn't have that. We would call the physician and say, hey, according to the American College of Radiology, this would be a more appropriate image. We don't want to touch this patient until we're sure that there isn't a fracture. And so that's because we haven't been able to order imaging, we spend a lot of time talking with our students about what imaging is appropriate, what to look for, so they know their indications, contraindications, precautions. They know when it's indicated, when it's not, and then they can call somebody and say, hey, we're concerned because we don't want to hurt anybody. We want to make sure that every patient that we see is safe enough to be treated by PT.
Representative
and so-
Shiree, got another question.
I do have another question.
Okay.
And please stay.
Oh, wait, never mind, stay.
Yeah.
Back.
Okay.
Stick to his-
Okay.
Stick to what he's
Okay.
actually asking.
All right.
Yeah. So I'll briefly touch on the diagnostic image. I know you guys are not asking for that, but when you see a patient, I know you don't have direct access, but if the patient's not getting better, they're actually getting worse with PT, what do you normally do?
I call the provider. And
Okay, good enough. If we were to allow you direct access, how many visits do you think would be appropriate to see a patient without referring back to the doctor if they're not improving? I'll just throw that out there.
It's a loaded question because it would depend on the condition. But I would expect to see in most cases, if it's certain conditions within just a few days, with others, depending on how long they've had, if it's a chronic condition, it would take longer. But I mean, if you're not seeing improvement in 3 to 4 weeks, that's a problem. That would be the probably absolute most.
Okay, thank you. I need to ask another question, but I've got all my stuff here. So we've addressed the malpractice, and those 4 PTs have been released, and there's been no increase in that. So you guys all pay the same malpractice whether you have direct access or not? Okay, it's pretty standard. I will address Nico. Will you talk a little bit more about the VA, and are you saying the VA is a lower tier?
Absolutely not. No,
Okay.
Representative Shirey, thank you for the question.
Sure.
I was saying the comparison between safety within the VA and safety in the fee-for-service world that you operate in optometry is very different. So in the VA, it's a closed captive network, right? It's people. You'll have an orthopedist walking down the hall, and you'll have PTs, and they'll be seeing each other many times a day. Athletic trainers and multiple other providers that are working in the VA system. And it's not, there's not prior authorizations that are done, to my knowledge. There's not visit caps and limits because the VA is providing that care. There's a whole separate process and system for that. Obviously, in the fee-for-service world, you've got carriers that have individual limits on the number of visits that could be utilized by an individual person for physical therapy. You have potentially prior authorization issues that could get bumped up to if somebody needs more visits. And so that was the distinction I was drawing, was that to say it works fantastic in VA, it may work really well, but it's a much more integrated network, frankly, than we have in the fee-for-service world, which is the predominance.
Okay, you touched on another question that I have for you, and maybe you can answer it. Maybe we need to answer somebody else. Do we know what billing codes? I'm sure the PTs know what billing codes they use to bill. And as far as restrictions from Medicaid, in my world, we use 99 codes and 9200 codes. And there are restrictions on the number of visits that you can have per year, to your point. Is it the same for PT? Is it limited? Emmett, I see you.
I don't want to answer something I don't know the
Sure.
answer to. You want me to stay up here?
No, dismissed.
You've got that one. It's the one you don't like.
So we typically build the 97,000 codes. And so payer rules are going to differ between payers. There's all kinds
Can
of.
we just address Medicaid then?
Okay. So I'm not the best one for Medicaid because we're not Medicaid providers. And I can address Medicare, but not Medicaid.
Medicare usually follows Medicaid, usually follows Medicare guidelines, in my opinion. But if someone else knows,
You could come up to the microphone, please.
There are some limits on services that can be provided for children, but typically children are treated long-term, and that's allowed under the EPSDT. So, but there are limits, and that's posted on the Medicaid website, how many units are available per year. And typically, physical therapists and occupational therapists sometimes, share some of those codes, so we have to be cautious on how many units that we use.
Do you know the unit numbers per year?
Well, I can't tell you that because it changes. I mean, it's different. But I believe 97110 is approximately 60 per year. But I don't quote me on that one.
Right.
Okay.
Thank you.
Wait a minute. Representative Shirey, are you done
I think
for
I'm
now?
done.
Okay, Representative Mooney?
Thank you, sir, very much. I don't remember exactly who had made the comment, but the comment was made that people go to unlicensed programs, and I just wrote down the question, who? What unlicensed providers or programs do they go to? I was just curious.
So what we see, frankly, is, and some of y'all might even do this, if you go to one of these competitive gyms or one of these performance gyms, and what you have is you have coaches that are doing things that fall into the realm of what we do as physical therapists. But it's because they have that person right there. So, say for instance, somebody, I don't know, they pull a hamstring. They're there with them. They don't want to get them out of there. They want to keep them there. And so they're doing stuff that falls into the realm of PT within a gym setting. And it's because they know they want to get seen quick. And because they know, hey, the quicker I get seen for these types of issues, we've talked a lot about back pain. Back pain is especially, there are tons of studies out there about early access to PT for back pain. United Healthcare, the largest for-profit insurer in the country, has recently put that out there and said, hey, we want for acute low back pain, we want them to go to PT first. In some states, they're even waiving patient copays because they recognize the effectiveness of it and the cost savings of it. So you have people that are looking for quick access to take care of problems that they have. And if they can't get it from somebody like me, they're looking to whoever's right in front of them. And a lot of those folks are willing to do things to help them.
So these aren't like athletic trainers. These aren't anyone that's got a
They're
license. of any type.
unlicensed individuals in the state of Alabama.
That's just interesting. I had not thought of that. A couple other quick questions. Let's see. A bill was mentioned in 2020. Would someone please share what the changes were in that bill, which was not brought forward, to the current legislation that this current legislation is referencing? I'm just curious.
Give me a minute to get through my 75 versions of everything. Yes, I do have it. Also, for the
I'm
record,
curious
since
if everything
we know,
that was in that bill is in this bill, or if there's anything
No,
in
it
that
is
bill
not.
that's not in this bill.
no, it added a couple of things and changed some days, and I am not finding it. I may call Nico up here to do it. I showed it to Paul yesterday. I've got it somewhere. But for the record, real quick, I own one of those gyms that he's talking about, and I don't do that. So I do not do that, and neither does my staff.
Well, I'm a product of MDs, PTs, ATs, and everything else. You have 2 full knee replacements, and you've seen everybody in the spectrum, including the radiologists and everybody else.
Representative Mooney, that bill did primarily 3 things. It extended the life of a diagnosis, the time frame for which a diagnosis was, for which a referral was active from 90 days to 120 days. Current law is 90 days. It also allowed an additional opportunity where a referral would not be necessary for a patient with a diagnosed chronic condition that was under the care of basically somebody that refers to physical therapy. So if you have, and I use the example of someone that perhaps had a car wreck many years ago, and they had a back injury, they're always going to have back problems. That's just never going to go away, unfortunately. And so if PT is appropriate for the condition that they're under active management for, they would not need to get a referral to continue seeing a physical therapist, because that's going to only help. Let's say they're getting back injections, interventional pain shots or something. PT would help for that. That's under an active management of a physician or somebody qualified in that space, and then that would not require a referral. And there was additional criteria that was more of a wellness and strength training dynamic, that as long as the patient did not present with a new onset pain, illness, or injury, I believe is the exact verbiage from memory, But as long as they didn't present with new onset pain, illness, or injury, then they would not need a referral. That's from memory. I think that was everything. Emmett may remember differently, but I feel like that was it.
Well, obviously, we don't have a sub to look at, but does this bill we do have in front of us, does it encompass those things from 2020?
I think there's so many versions. I don't know to
He's
speak to
talking-
which
I
two.
can do that. I got
Okay.
that part. My bill, the original one that we are discussing today, is direct access. It does not have any of that in there.
So none of those things from 2020 are in the current bill, but could possibly be in the
The current
sub.
one I filed, yes, sir.
Okay, that answers that one. And then there was one other question. I probably misunderstood this being said, but I thought I heard someone say that physical therapists do not do Medicaid patients. Was that correct?
Some don't. I think some do. No.
Okay, so it's a credentialing issue. Thank you. That was just clarity questions.
So I have a question. So are there limited days on Medicaid? Was that the same answer you get? Okay. 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 How many, just curiosity, how many cash people come in to pay cash in a PT? What percentage? Any idea?
So we've looked at these numbers. The number is actually growing as deductibles have skyrocketed, out of pocket have skyrocketed. We create cash programs. Sometimes it's like a retainer based, you can get this many visits for this amount and so on. So the numbers actually increased quite a bit. I would say at times we've seen as much as 15 to 20% are on some sort of cash program. But again, that's because they've got such a large deductible. And if they were, we try and give them a little bit of a break by, purchasing the visits up front and stuff like that. But it's definitely becoming a bigger issue.
Okay. Thank you. Are there any other questions? We'll come back, but what I would ask Representative Lipscomb, we have thought we had the latest copy. We do not have the latest copy. We're going to try to get it to you. We had the wrong one, but Representative Lipscomb, because we may all be arguing over something that no need to if we didn't have the correct one. So let's lay it out there, if you can do it off your memory.
I'll try my best, Chairman. Thank you. So, as many of you know, we have had 2 meetings with a subcommittee, in which case we've sat around a round table. We've had the protagonist, antagonist, and the subcommittee members discuss it in an open environment so that we can try to determine if there's any compromises to be had. And what we would do is we would take those comments, create bullet points. Where we could get together, that became a set in stone issue. And where we couldn't come together and there was a stalemate occurring, I would get together with our committee members thereafter to try to gauge them on their opinions of the matter. And sometimes, in some cases, there was a stalemate among us. So it was incumbent upon me to do my very best to create an equitable solution to the matter. And as such, we've created a couple of different substitutes, 2 iterations, as a matter of fact. The most recent one came out late last night, which we do not currently have in hand. But I'll do my very best to try to go through that and explain what we are trying to accomplish. The first thing, and I'm doing this from memory, so please forgive me, we had to create a definition of what the physical therapist or who the referrer was. We didn't actually have language in the bill to explain who that was, so that was a definition that was created. We did have some antiquated language in the bill relating to physiotherapists. The terminology RPT was included in there. That is apparently an antiquated term that we're striking from the code. We were addressing what a physical therapist may or may not do without a referral, And in order to, let me see here, basically stating that a physical therapist may not treat patients without a referral from a physical therapy referrer unless the following categories took place, and we defined those. I'm not going to read those out because I don't have that correct information in front of me. Okay.
Check and make sure that's the correct one, please.
Okay, this is correct.
Okay.
We defined physical therapy referrer as a, and this is already in the code. We're just pointing back to it as stating a physician licensed to practice medicine or surgery, a dentist, chiropractor, et cetera, et cetera. Struck the language RPT. Further along, we struck some of the old language, which is common in all bills, through line 177, and then we inserted the following. A physical therapist may not treat patients without a referral unless they possess a doctorate in physical therapy or an equivalent degree, or possess a doctorate in physical therapy or equivalent degree from an accredited institution. We had just a couple of different options there because they were slightly different. In addition to those, we added 2 hours of continuing education focusing on professional standard of care. We want to make sure that the PTs, if they're going to be working without referral, that they know when they should be pointing back to the back to a referrer in the case of a decline in their condition. There is some standard language basically saying that you need to maintain a standard of care. I'm trying to get to the important stuff here. We have a section which has been probably the most contentious section in this bill, a physical therapist meeting, and this would create a limited scope, not a full or an excluded scope, but a limited scope. A physical therapist meeting the educational requirements of subsection A may perform physical therapy on a patient without a referral from a physical therapy referrer for no more than 15 calendar days or no more than 6 visits, whichever is shorter, after which the physical therapist must receive a referral from a physical therapy referrer in order to provide any further treatment. These treatment limitations shall not apply to any of the following: a child with a diagnosed developmental disability, patient of a home health agency, I'm leaving out some language to be expedient, a patient of a nursing home pursuant to the plan of care, a patient previously diagnosed with a condition for physical therapy services are appropriate after informing the physical therapy referrer. Previously in your code, that condition applied to a 60-day precedent. We increased that to 120 days for your benefit.
It actually is 90 days, just, I don't know, somewhere.
Well,
around there.
excuse me. Well, we did increase it from the previous up to 120. A patient with a previously diagnosed chronic condition.
That was part of the 2020 agreement. Okay.
No. They were going to amend it to 120 in the 2020 agreement, but 2012 has 90 days.
Yeah. Education or activities relating to wellness, essentially sports training. The licensed physical therapist shall immediately refer a patient to other healthcare providers upon a measurable deterioration. I think that's clear and obvious. I'm going to skip to only the important parts here. Forgive me.
So, Mr. Chair,
Yes.
is the point in him having him to go through it is that we have not completed this process, and
That's correct.
Much of the remainder of this is not worthy of being read to you.
Okay.
Thank you.
I think the remainder of it should probably be best disseminated by reading the substitute itself.
All right, so what we're going to do, I think we're starting this afternoon, trying to work something out. And this is, first of all, are there any other questions? Is it clearer or muddier than ever before? Muddy or okay. Well, we're going to clarify it, but what we're hoping to do is to come to some sort of agreement on this to make sure that our people have access. One, that's important, and then there will have to be some restraints on how far that would be. I think everybody in this room understands both of those issues. And on a personal note, I talked to Nico in my office just a few minutes ago. I think if anybody's paying cash and the insurance not involved, Medicare not involved, they ought to be able to go anybody they want to. That's just my opinion. And so that is should be in there. And then another question I have when it comes to that we need to address, we're talking about the doctorate and the master's. Most of these clinics have 6, 8, 10, 12 PTs working, I would guess, in there. Do most of those have a doctorate or a master's person that is over that area, or some do? Most cases they do. If that is the case and we're good with that, then we need to look at an umbrella just like we do in any other type doctor that allows so many people working under them. We need to have an umbrella. I know we've expanded that, Nico, over the last 18 months or so with, what was it, nurse practitioners under physicians, that we need to address that as well and make sure that one person doesn't have 45 and not being able to contain and maintain those. So that's we have some working orders, marching orders to try to figure out, and we will be back here hopefully next week and we can address it with a bill that.
The following week.
Well, y'all can come next week. I won't be here. Week after next. So we have plenty of time to come to some sort of agreement on that. Any other questions before we dismiss? Thank everyone for your time and being patient, and that's why we're trying to do it the right way and get it done correctly for the future. Thank you.
Thank you.